Hi, everybody. I know that some of you on the West Coast are probably just ending your day, and I'm going to give those people I think maybe an additional minute or two just to get online. A couple of housekeeping things. At the end of this presentation, it's going to last about 50 minutes, and I'm going to save the last 10 minutes for questions and answers. So you'll be able to type those in, and then I'll just go through them and answer them at the end. Okay, so just kind of hold your questions to the end and we'll get through them all, hopefully. um, Also, at the very end, um, we'll explain how you obtain your CE for this webinar. So I'll just introduce myself for those of you that don't know me. I'm Dr. Donna Galante, and I'm an orthodontist, board certified. Private practice for 35 years. And in fact, 35 years this May. Graduated from the University of Pennsylvania. Did both my dental school training and my ortho training there. Husband and I are both orthodontists, and we have been huge providers of Invisalign really since 2008. We're Diamond Plus providers. 90% of our practice is clear aligners. And what I'm going to show you tonight is how we use clear aligners and high frequency vibration, specifically the Propel V Pro device, to enhance our patient's experience, as well as enhancing our results and helping our patients get through treatment on time, maybe even a little ahead of schedule with minimal discomfort. And I think hopefully at the end of this, if you haven't tried Propel, the V Pro, you'll be encouraged to do so. I do think for my husband and I, it's been a key appliance for our practice to keep patients on track, on schedule, and even those patients that sometimes aren't necessarily 100% cooperative with wearing their aligners, we're still able to get great results and still finish on time, which is what we all want. Patient wants it, and we want it as well. So I'm going to get started now. And like I said, at the end, we'll go through some Q&A. So save your questions till then. So speaking of questions, these are the questions my husband and I were asking ourselves. How can we get our adult patients to finish treatment faster? When we would look at our adult patients, we would see consistently overtreatment. And we're talking about clear aligners, right? Overtreatment. Sometimes, you tell a patient it would be 12 months of treatment and they'd be finishing in 24 months. And that doesn't work. You've got to be able to get patients in and out of treatment in a very timely fashion. We also noticed we had a lot more tracking issues with our adults. And we wanted to figure out, well, how can we get them to track better? And of course, some of the tracking issues came down to the fact that they were taking them out, because as soon as the aligners hurt, they took them out. So how can we reduce or eliminate that discomfort? How can we stop? I call it the inquisition at each visit. They're not tracking, they're behind, they're still on aligner number 4 when they should be on aligner 8, right? And then you're asking them, how many hours are you wearing them? Doc, I'm wearing them all the time. It just becomes a very uncomfortable process. And then the patients don't want to come in and see you because they just know they're going to get grilled. How can we reduce the number of appointments? In this day and age, even I think most of us would have never realized in this day and age how much patients really don't want to come in and see us, right? Well, how can we reduce the number of those appointments even further? And I think V-Pro, high frequency vibration, helps answer that question. Can we add value? Is there an appliance that would solve these problems? And is it easy to use, takes minimal effort and time on the patient's part, and is affordable? Well, the answer is Propel V Pro. And I'm not going to spend a lot of time tonight on the science. There is so much research that's been done. And I'm sure if you are interested in getting this information, any of your local Propel managers can get those articles to you. But the things that were really the most important, as far as I was concerned, is the fact that you get some physical seating. Like it really helps, like it's like a major appliance seater. There is reduced pain. I never tell patients they're never going to have any pain, but I say it really helps ease the discomfort of tooth movement. Okay. I find that we can recapture those non-compliant patients. The patient comes in, the aligner isn't seating all the way or tracking as well. Get them to start using that V Pro, because I'll be honest with you, they come in and if I see a non-tracking appliance, I just say, look, when was the last time you used your V Pro? And they'll say, oh, I haven't worn it in like 5 days. I haven't used it in 5 days. I'm like, yeah, we need to get back on that. It's really going to help make that aligner seat, and it's going to get those teeth to move the way we want. And of course, and I'll talk a little bit about retention at the end, that Propel, the patient, it's theirs. We tell them when they get their retainers to continue to use it once a week. We usually tell them it's a Sunday night chore. You got to use it for 5 minutes on a Sunday night, before you go to bed. And that's to make sure that retainer is fully seated. If that retainer stays fully seated during the retention phase, then you're going to have 0 relapse issues. So I'm talking about the vibration device tonight. Propel does have mops, right? And we don't use it that much. I will use it in very localized situations, but every single adult patient in our practice gets the V Pro, the vibration device. So I'm going to show you a potpourri of cases tonight just to illustrate, how well this can work. And just like, every patient out there in the world, there's always a story. And this gentleman named Michael comes in and lets us know that he's wants treatment, but he's moving in about 9 to 10 months and wants to get done before he moves, right? And I know you've heard that. So looking at Michael, class 1, he's got some wear, right, from Brexing, and he admits he's a big Brexer. Some alignment issues. He says he doesn't like to smile. That's what he told me. I just don't like to smile. Had his wisdom teeth removed. It's in good health, good periodontal shape. So the plan is about, he needs to be done in about 10 months or less. So we are adding the V Pro into his treatment plan. So again, I'm going to show you tonight Invisalign cases, and I will go over some key strategies that I use to set these cases up pretty consistently for success. So when it comes to a deep bite case, I have a certain protocol I follow with every single deep bite patient. And the first thing is bite ramps. So you'll see here, I'll just run the video on the upper. These bite ramps go on and they stay on the whole treatment time. Now that lateral tooth number 7 didn't go on until later, and that's because that tooth was jetted out a little bit. So the software will automatically put it on once the patient can actually bite on it. So bite ramps to me are key to success because most of I'd say all your deep bite problems, a vast majority are lower arch problems. The patient has a very deep curve of spine, and you're trying to level that out. And a lot of that leveling, honestly, the part of it that's most predictable is the lower anterior intrusion, really getting that lower anterior intruded in order to level that curved spine out. You can build in some posterior extrusion, of course, and I do, okay? And you can see it on these occlusal contacts because I usually like to see them in red, which means a bit of over treatment, right? But I'm really counting on, what I really count on, honestly, is the fact that at the end of treatment, he is not hitting heavy from at least the lateral to the lateral. I expect the canines to be touching, to be honest with you, even though I take him out of occlusion. I'm building in, I always call it, I'm hacking the software. I'm building in some overcorrection to allow for the fact that what you see on this ClinCheck isn't exactly what's going to happen. And a lot of it has to do just with aligner lag, compliance, of course, patient biology, right? The degree of his clenching and grinding. So here he is, and so here he is at the end of 5 months of treatment, and quite honestly, he was happy. He was like, "Wow, I'm so happy. It's just time for my retainers." And of course, being the Type A orthodontist that I sometimes can be, I said, "No, no, no, we're not done yet because I see this one tooth down here. These two teeth were out of alignment." So he's like, "Okay, fine. If that'll make you happy." So we went back in. And I knew we had some time because, he had said, he wasn't moving for like 10 months. So we had like another 5 months, but obviously I'm not going to give him 5 months of aligners. You can see based on, remember that setup I showed you? You can see based on that setup that it wasn't like I left him with an open bite, right? And I'd say we were successful in actually preventing a posterior open bite, but this was my issue right down here. I really just didn't like the way those two teeth looked. So we got those teeth lined up. We did a little bit more bite opening. And you can see I still kept the bite ramps on. He is a bruxer and a clencher, right? So they stay on the whole treatment, all right? In fact, even in his retention, which was Vivera's, we had the bite ramps on there. Clenchers really need those bite ramps. So here he is, 9 months of treatment. Here's before and after. And I think you'd all agree. I mean, it wasn't a really difficult case, but it could have easily gone out to a year had the patient complained about sore teeth or wasn't cooperative, so to speak. So my tips here for deep bites: you want bite ramps, you want red contacts on the posterior teeth. I do not expect heavy contacts on the posterior. I'm just expecting contacts on the posterior, and I want to eliminate any interferences in the anterior region, because most of what I'm attempting to do in solving the problem is lower anterior intrusion. Yes, I build in some posterior extrusion, but that is a much more challenging movement, especially on a patient that's a clencher and a bruxer. Miss Lori is 55. Chief complaint, I think you all would imagine, would be tooth number 10, of course, tooth 26 there on the bottom. So she's mostly concerned about those teeth, and rightly so, as you'll see when I show you the ClinCheck. Tooth 10, the upper left two, it's about a 45-degree rotation. So I had told her about 12 to 15 months of treatment, but we did add the V Pro. And one of the things about this particular case that I want to highlight most of all is that lateral incisor, because I think we all know how difficult those teeth can be to rotate, right? With aligners, with plastic, right? So the advantage of having that V Pro in there, and she was a very good patient, very compliant, but having her use that 5 minutes a day, and sometimes patients will use it more than once a day, and I'm okay with that. If they feel that it really gives them comfort, patients will tell me it feels like a tooth massager. Like if their teeth are really tender, I tell them, yeah, if you want to use it, once in the morning, once at night, I mean, it's really up to you. It's not going to hurt you to do that. But you can see the amount of rotation. And if, we all had about $100 to bet, we'd all bet that that tooth would be a problem tooth. It's a lot of rotation. And you can see if you use this tooth movement assessment tool, it is a black movement, right? And you hover over that and you get 40, what is it? I apologize. It's almost 50 millimeters of rotation. It's a lot. So again, I think it's important to look at things like that tooth, even this tooth that's so lingually displaced, and think to yourself, okay, those are the two teeth that are probably going to cause me the most heartache during treatment or the most tracking issues. Everything else, is my standard protocol. We're, intruding the lower anteriors. We're putting in those red contacts in the posterior. She's got the upper bite ramps, right? So it's all standardized, but we have that upper left two in particular is a challenge. And you can see it didn't do so bad. I mean, it's not perfect. It definitely needs some extrusion, but not bad. 50 degrees of rotation in 7 months. Pretty good. So I'm not going to show you the ClinCheck. We went in and this tooth needed to be kicked out just ever so slightly, like 0.5 millimeter, and we had to extrude this down about 0.5 millimeter. And here she is at the end. And again, 12 months. Like I said, I don't promise patients that they're going to finish in half the time. We never tell them that at all. We just tell them the biggest thing we highlight is that it reduces any discomfort of tooth movement. It'll keep them on track to finish on time or even a few months early. And it provides full aligner seating, which is what you want, because if the aligner is seated all the way, it's working the best way possible. They get that. And that's kind of our selling point on it. So I did on the refinement add a little extra space to help with the extrusion and the rotation. It was mostly extrusion that she really needed. So now let's talk about crowding. Ben is 20. He's getting deployed to Afghanistan. So this was a few years ago, of course. And he needs to be done in 8 months or something. It was I'm like, oh my gosh, Ben, could you come in sooner? So we take up the challenge. He's going to be in aligners. He's going to have a V Pro. The wisdom teeth, I honestly would have liked those out before we started treatment, but he's going to get them out when he's overseas. So he didn't want to do it in the States. So I'm going to show you how we set the case up. So with crowding cases, I also treated him kind of like a deep bite situation as well. And I think you can see 7 and 10, the laterals are kind of small. So we did have a bit of a bolt-in discrepancy, and you'll notice in my setup that I did not do any IPR. And I purposely did it that way because we never really had a chance to discuss the fact that those teeth were a little undersized and that maybe he would want to do some bonding. So you can see that I got him out of crossbite, but I left some space mesial and distal. And again, he's, I didn't have the conversation, probably should have had the conversation, before I started this, knowing that we were on a time crunch. But I think you can see here that we pretty much got what I created, which was space around those laterals, which he did not want. And we did have to go back in and do a refinement and add that IPR. So as far as tooth size discrepancies, crowded cases like this, probably a good idea if you suspect a tooth size issue to have that conversation with the patient, because I could have gotten this done in that first round. And to be honest with you, I think he would have been done, right? I wouldn't have had to do this. What was it, like an eight-week refinement or whatever it ended up being. Fortunately, we still got him out of treatment. He was leaving in 8 months, so we were done in 7. So we were still in great shape. Okay, got him some Viveras and off he went. And here's his before and after. And I think you'd agree 7 months, it could have been less, right? Probably could have been 5 months, right? Had I been proactive and just done that lower IPR. Again, same thing, you want the red contacts on the posterior teeth. And IPR, by the way, I like to do it all at the same time. I don't care where it happens, but I just don't want the patient to come back multiple times. I want to get it one and done. I call it one and done. Sometimes the patient does need it again, but try to get the bulk of it done at the same time. Another crowded case is Miranda, and she's a local teacher, and she was complaining about mostly her upper laterals sticking out and those lower anterior teeth. Nothing remarkable other than those wicked third molars on the lower, which we encouraged her to get those out. But I told her I could start the treatment even if those were in, because we weren't doing any AP correction. So they really honestly weren't in the way. Again, V Pro, patients are instructed first day to start using it. And a lot of times on that very, very, very first day, they sometimes have to use it a couple times a day because their teeth are kind of sore, and it really gets them over the hump, especially that first week of the first aligner. Again, some things that you'll see here that I did, nothing too remarkable. There's some bite ramps. Again, rotating those laterals, making sure I had space to do it before. So you can kind of see we're doing a little proclination here. Teeth are getting pushed out, and then those laterals start to rotate. I think that's key. You know, if you try to rotate teeth before there's room, you're going to run into some problems. Also, the lower arch was very crowded. And one thing I want to flip it a little bit, the view. You'll see, you know, especially on patients that have this overlap in the front, and then you do the alignment, you're going to expect to get some dark triangles. I'd never address that with the patient usually in the first round, because I don't know if that's really going to show up as much as you see on the ClinCheck. A lot of times it doesn't look as bad in person, but look how much I opened your bite. Okay, I just wanted to demonstrate that to you, okay? It's a lot. And I want you to see what happened. And she's a good patient. She could be a little bit better, you know, like she told me sometimes during the day she would take him out when she was teaching. She didn't like speaking with him in. So you can see there's some alignment that didn't occur down here, okay? But all in all, you know, she's pretty happy. We're going to go back in and fix that lower alignment. And she does not want any IPR, by the way. I brought it up. No interest. My teeth are already too skinny. I don't want them shaved down. So here you are. This is where she is in refinement. Now, look at this. Remember how much I opened her up? So this is what I'm talking about. Like, you just have to plan for some compliance, some biology, what I call reality. You got to plan for reality. And the reality is that, you know, if you set the ClinCheck up ideally, sometimes you'll be disappointed because the patient's bite will not fully open unless you get aggressive. You saw that I had aggressively opened that bite. And honestly, it didn't, she didn't have an open bite. You know, we only had to do another 8 aligners, and here she is done and very happy. All right, no IPR at her request. So that was how we ended the case. But look at this, 5 appointments, 1 refinement, 8 months total treatment time. So again, these cases are the types of cases that, you know, everyone's happy when they're done. She's happy because the treatment took, actually, I think I had told her 10 months, so it took 8. You know, they're happy. They like when you finish on time or maybe a few months early. The bite ramps are key in my book for deep bite correction. I use the G5 features, which are part of the Invisalign deep bite protocol. Again, the key is, though, always building in a little bit of over treatment, over intruding the lower anteriors, maybe doing a little bit of extrusion in the posterior for those heavy red contacts. We're going to go into class 3, and going to show you Mr. Scott here, who is a dad of 3 little girls I treated. I actually treated his wife and his kids, and he says it's his turn. So we all can see he's had previous treatment. He's missing all his wisdom teeth as well as his premolars, first premolars. And we are going to do the V Pro. I estimate 18 months. And the biggest reason I estimate 18 months is that he is commuting back and forth from San Francisco, which is 2 hours away. So he basically, during the week, lives in San Francisco. So we were only seeing him on Saturdays, like once a month when we were open. And if he missed a Saturday, sometimes we didn't see him for quite some time. So you'll see this is my typical edge-to-edge class 3 setup. It includes class 3 elastics. And a lot of times these patients, not a lot of times, it's imperative that they wear their elastics. And I do build in some lower IPR. It's fairly aggressive at 0.5 and 0.4. So if we have a side view here, you'll see I use like an elastic simulation approach here. And I'm anticipating that he's wearing them, right? Because the simulation approach is showing you the correction, right? If he doesn't wear them, you're not going to see this bite change, right? So the IPR was done a little bit later in treatment. Could have been done very beginning, quite honestly. It probably should have been done right in the beginning, knowing that he's has trouble coming in because he is living, you know, half his life in another city. But with that being said, I really emphasized to him the importance of the elastics. And unfortunately, he was not a fan of the elastics. So you can see he wore the aligners fairly well, to be honest with you, right? Teeth are pretty straightened out, right? But he hated wearing those rubber bands, and he pretty much admitted he only put them into bed at night, which I think all of us know that's just kind of a waste of time. It doesn't do much. So I got him back in. We did a refinement on him, and I didn't even bother giving him elastics because why bother if he's not going to wear them? Because he pretty much told me I'm just not going to wear them, right? So I set the case up as best I could with the understanding that he's not wearing elastics. So again, because he didn't wear the elastics, we ended up with some contacts right here, right? Which is causing, which is holding up the whole case. So go back in, really didn't want to do any more IPR because I was pretty aggressive in the first round of IPR. So now I'm just building in, and this is very typical of my class 3 cases. Let me show you from the side view. And this is why class 3s I think are very challenging, because you're fighting this constant lingual crown tip or lingual crown torque, whatever you want to call it. You're fighting that the whole time, especially with class 3 elastics. And so putting these power ridges in, you're trying to build a little bit of lingual root torque. But my main goal was just to open the bite enough so that he wasn't hitting on those front teeth, okay? Kind of treating it almost like a deep bite case. And then here he is at his final. And he's still a little light back here, but it's definitely improved, but he's not hitting heavy here. So he just wanted to be done. We put him in retainers and 18 months of treatment. So the moral of the story here with Scott is, you have patients that are non-compliant. You have patients that maybe commute, they live one place during the week and come back on the weekends. Or I have patients that live half the time, in California, the other time in Hawaii, or, half the time in California and half the time in Utah. So it's interesting, the world today, and we can treat those patients, and combining clear aligners with a V Pro kind of gives you that comfort that as long as they're using that, the aligners at least will track. I mean, obviously on him, he wasn't really good about wearing the rubber bands, and that's kind of where maybe, we have the challenge in really getting the bite exactly where we wanted it. Again, I usually have on my class 3 edge-to-edge cases always some lower IPR, class 3 elastics. This is my typical setup. This is literally what I type in to the technicians as far as the special instructions. And the biggest thing that's probably the most important is providing 10 degrees of lingual root torque on the lower anterior teeth, because that is really the hardest part of this whole deal here, other than the patient wearing the rubber bands, right? That you need them to do that. So let's look at Matt, and Matt's going to be a bit of a combination problem, a class 3 with an open bite pattern. And you can see here on his pano, we've got a bridge up there, which complicates things a little bit. But biggest complaint with him was, not being able to, bite into sandwiches. He was complaining about his bite mostly, and obviously some alignment. So again, Matt's going to do clear aligners. He's going to be on the V Pro, 5 minutes a day, every day. We tell them it's an everyday thing. It's not like once a week, it's every day. So this is a very similar setup to what you saw before. The only difference is we're dealing now with a bit more of an open bite. So you'll notice that I do some posterior intrusion, and then you're going to see a little bite jump at the end. Let me try to stop that for you. So, typically with an open bite setup, and you don't have to do it this way, you can see that I built some intrusion. It's a fair amount. And I figure the amount that I put in, I'm going to get 50% of that at best. So I don't get too nervous that I'm over intruding, because it's really not going to happen. Because I realize that even if the patient is, wearing these aligners, 25 hours a day, and doing his V Pro, biologically, it's super hard to intrude these lower molars, quite honestly. I'll have better success at getting these pushed back up, right? So you have to build some overcorrection in order to kind of get the kind of results you want. And it's super important that he wear those class 3 elastics, because once he auto rotates, you'd be in a full-on anterior crossbite, right? So the good news is Matt is a super patient, really compliant, wearing his aligners, using his V Pro, doing the deal, doing the elastics, but he doesn't like those dark triangles. And otherwise, he's pretty happy. So we have to go back in, do a refinement. And I guess I could have predicted those dark triangles, and maybe I missed it in that first clean check. Probably should have put it in there and saved myself a refinement, right? So sometimes I kind of kick myself, but not being proactive on it. But again, if you remember Miranda, she didn't want any IPR. So again, sometimes I think with the IPR dark triangle issue, if you place it at the very tail end of the treatment in the first round, the patient wants it, great, do it. Put it at the very tail end, patient says, I don't want that, then you're fine, right? Don't do it. So then you're done. If it's like right at the very tail end, and then maybe you order like 3 overcorrection aligners to just close up whatever space you created. So I had to go back in for a short period of time and just do the IPR. It's not a big deal, right? But you can see that, he was in pretty good shape even before I did the IPR, but that just obviously is going to give him even more clearance and prevent any sort of anterior interferences. Here he is at the end. This is his final scan and 11 months of treatment. And we did the V Pro. So again, class 3, open bite, less than a year, right? I just know from the past, even the best patients in the world, we would have not finished this quickly without that V Pro device in there. So Matt kind of leads us into our last group of patients, which is our open bite correction with Invisalign and V Pro. And Brittany, again, is a retreatment. Comes in, had treatment as a teenager, and she is relapsing. Her bite's opening up. She doesn't like the way her canines are looking, right? And she is complaining about the lower crowding as well. All right. And again, open bite patients, getting those third molars out actually helps a lot, right? She refused to get those third molars out. And in a way, I don't blame her. There was nothing wrong with them. They were good teeth. But, if it's a real severe open bite, I make it mandatory. Hers wasn't, like I said, it was more on the mild to moderate side. So anyway, left them in, okay? And you're going to see here, again, posterior intrusion. And on her, I'm a little bit more aggressive on the anterior extrusion because she really was complaining that she felt when she looked at her smile that she had these fang teeth, right? The canines were hanging down. So a little bit more aggressive on extruding 2 to 2, right? And giving her that smile arc, right? There's that beautiful smile arc, right? And that's what she was going for. But at the same time, that's happening. I'm doing this in the posterior, and you'll see, you can again hover over some of this. Well, that says extrusion, which is kind of weird. But if we kind of go and let's just look at the superposition, which to me tells the whole story, and we just click to the end, you can see we got a little bit of extrusion on this tooth because we're trying to get a little bit more torque on it, but we did intrusion on all the posterior teeth as well as the lower also, right? Especially that lower third molar, which is very difficult. This is very, 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 very difficult, okay? It's, just honestly, intruding molars on the lower in general is a tough move. So here she is 5 months later using her V Pro. We're getting there. Her bite's definitely not right. We got some contacts here and some contacts there, but things are still pretty unstable. Happy with her smile. She's liking the way her canines don't hang down so much anymore. So we're going to go back in and really try to nail the bite so that it's a lot more even for her. In fact, she was such a champion of aligners and the vibration device. She actually did a few little videos on her own Instagram. I think it was her Instagram account. Yep. And talking about, her experience at our office. It was really wonderful. So here she is. You'll notice that she has, some contacts here, some contacts there. It's not super even, right? So we're just going to go in and try to solve it. We did do a little bit of IPR on the lower. I felt like we wanted to get rid of some of those dark triangles that were unattractive, and we mentioned it to her and she agreed. So we did some IPR and just trying to close down things so that she's kind of hitting evenly all around. And here she is finished up. And you could argue that still doesn't look 100% here, but sometimes I find if I spend too much time trying to close down that posterior open bite, I get myself in a problem here in the front. So we usually give them their Viveras, have them back a few visits, make sure things are stable. And if there is some issues later on, you have the opportunity to do another refinement. We always kind of leave that door open for them just in case. But 5 months, 5 appointments. And last one is the one that really you got to kind of look at and kind of have an open mind to, because this one is a crazy case, honestly. Sophie's 26, and you can see besides the open bite, right, you can see some severe crowding on the lower, very narrow arches. She's got third molars in there and some recession and very thin bone. I don't have a CBCT, but I think you'd all can tell that, we're really, really pushing the outer limits there. And even on the Ceph, you can see on the side view on the lower. The wisdom teeth are going to be removed before installation of the first set of aligners. So those are coming out, all right? So that she had to do. Now, she was adamant about not having any other teeth pulled, and I know that most of us would look at this case and want to take out some teeth. So let me just show you what I did. So again, we have here the very narrow arches, thin tissue, thin bone. And then I decided to put her on some class 2 elastics, which she wore mostly 12 hours, 14 hours a day. I built in some sequential discalization, some expansion, and you'll notice that a lot of IPR on the lower. It was aggressive IPR, probably the most aggressive IPR I think I've done, quite honestly. And the whole time, really having her be involved and really monitoring what was happening, especially in the lower anterior region as far as the soft tissue and the recession. All right, but I mean, obviously a case like this, many of us would have considered, 4 premolar extractions along with the wisdom teeth, right? So it would have been like 8 teeth out. And she was not keen on that idea. But I want to show you the, look at that crazy open bite. Now, I know you're looking at that and thinking that is the worst setup I've ever seen. But you have to remember, because it doesn't have a bite jump here, that hopefully if everything goes according to plan, she's going to auto rotate. And that's kind of what she did. And here she is at her first refinement and decided to change to a redhead, which is fine, looks great. But look at the results so far. We have a posterior open bite, so pretty successful at getting the intrusion. She auto-rotated forward, so we don't have that huge overjet that was shown in the ClinCheck, but we still have a lot of crowding on the lower. So let me show you the setup for this first refinement. And I know I did a ton of IPR, and I went back in and did a little bit more. And again, with the Invisalign software, they assume that you did 0.5, right? But I might have not, So we're going back in to do about another 0.2 because things just did not line up. And I took her off the elastics at this stage of the game. We didn't need them anymore, right? She was fine. She was class 1. Overjet was more or less solved. But we did have to kind of organize the bite a little bit better. We had to get those lower anteriors aligned and make sure, she had full contact on those posterior teeth. So here she is at the final refinement. So this is a second refinement. Now she is a blonde. We were quite intrigued with the hair color changes each visit or each refinement. And I'm starting to notice that, remarkably throughout this whole treatment time, despite all the expansion, despite, a lot of the movements that we've done, even with the class 2 elastics, we're holding tight to the position of those lower incisors. Things aren't getting worse as far as any recession or any sort of dehiscence. Here is the last refinement. It's a very short one. We're just going to just kind of dial in the posterior at this point because she's kind of open. Kind of maybe did a little bit too much intrusion, and I just want to get that fixed. One thing that's super important to remember whenever you do any expansion, those molars will tip out a bit. So you really got to be careful to build in some buccal root torque because they do tip. And that is kind of an unfortunate thing on the upper arch that happens. The plastic just doesn't, and you can kind of control it if you add some attachments on the buccal. But even when I've done that, I still find it tips unless I really get aggressive with my buccal root torque. So you got to really pay attention to that, especially on cases where you've done a decent amount of expansion in the molar region. So here she is now at the end of 15 months. This was 15 months of total treatment time. She's still a little open, kind of left her like that, knowing that she came in with a pretty good open bite to begin with. So I'm building in a little bit of relapse that invariably will occur. But I think you'll see there's her final pano. The third molars are gone. But look at this before and after. It's quite remarkable, the amount of width we got. I think you'd agree that I don't think I caused any more recession. You could even say, maybe that tooth improved a little bit. So did that canine possibly. And then if we do a side by side, you can really get the feeling that this canine improved tremendously from where it was, right? Just visually. I'd say this canine certainly didn't get any worse and maybe even got a little bit better. So it's quite remarkable. I really hadn't studied this case that much until, I was preparing for this and realized that it was incredible how well her soft tissue and bone held up. And I really have to think that although, VPRO doesn't have any data on this, I have to think that a lot of it may have came from the fact that that VPRO was there and helping redeposit bone as we were doing the movements. So again, open bites. Ideally, I set them up with heavy contacts on the anterior teeth, right? Unlike the deep bites. I do use optimized extrusion attachments. I do like them. I do find that, you still have to build a lot of overcorrection. You can't make it perfect. You've got to build about 1 millimeter more than you expect. Intrusion on the upper teeth, I think, is relatively predictable. Lower, I still do it. I still build it. It's just not as predictable. And here you can see you've got to build that anterior extrusion and you've got to overdo it to get what you really want. So in summary, every adult patient gets a VPRO as part of their fee. We actually include it in the treatment fee. So they don't have an option. It's just there. It's included. Okay. 5 minutes a day, every day. Sometimes that first week with the first set, we might tell them 2 times a day or even 3 times a day. Our patients are seen about every 12 weeks. Usually in refinement, it says 16 weeks, but a lot of times in refinement, they only have 8 aligners. So then they're back in about 8 weeks. They change them every 7 days. People always say, well, you're using the Propel device. Why aren't you going faster? You know, it's easier for patients to remember 7 days. Propel has some really good research showing that 7 days was where they saw the best bang for the buck, so to speak, as far as high frequency vibration and the results. If a patient really is feeling like after 5 days the liner is so loose or not much is happening, I let them go faster, but I don't dictate that it's 7 days pretty much. Most of your adults aren't wearing them 22 hours. So if you get about 18, 16 out of them, 7 days is probably right on the money. It definitely impacted the patient experience. We don't spend a lot of time talking about how many hours they're wearing their aligners. It's more like, you know, are you using your V Pro? It looks like some teeth aren't tracking really well, right? That's kind of the conversation. We find that they track well, even if they're not wearing them 22 hours a day, which is probably about half of them. And it added value to our treatment because our patients are finishing treatment on time. You know, they're just blown away that, you know, we can get this case done. And we've heard stories, my girlfriend, she went somewhere else and she's still in aligners. Like, I'm done and she's still in it and she started a year ahead of me. And again, sometimes I don't know exactly what her girlfriend's case was, but again, that patient perception is everything, right? And they perceive that, wow, I got through treatment on time or a little ahead of schedule and I had very little discomfort. I would say, a couple of the cases I showed you for sure, it could have been one and done, right? So it was my bad for not being a little bit more proactive on adding some IPR, like on that two sides discrepancy on Ben, or on the patients who had the dark triangles, like just being proactive. I probably could have eliminated a refinement. But what I do see is that, except for that last case that I showed you, right, where we had 2 refinements, which was very severe, we're nailing it with just 1 refinement, and even then the 1 refinement is pretty minimal. And then last is retention, which we have patients continue to use it once a week in retention. If they find that they are seeing teeth move, like they take the retainers out during the day and the teeth are moving, we tell them that they need to use their V Pro. They need to bump it up to twice a week. So maybe every Wednesday and Sunday, okay? Patients stop wearing the retainers. They're on vacation. They forget to bring their retainer. Teeth have moved. They need to kind of get that V Pro in there every night now to make sure that that retainer is seated and we can get that engagement and alignment again. So this is from Dr. Chipley. End of treatment, patient had perfect straight teeth, poor retainer compliance. Here you can see 1 year post-treatment, patient wasn't wearing the retainer as prescribed, used the V Pro, got it down, 4 months later, totally lined up again. So again, just because the patient is done doesn't mean the V Pro gets put in a drawer and forgotten about. They can continue to use it and maintain their beautiful smile forever and ever, and make sure those retainers are seated fully. Because I got to tell you, if you can't get those retainers down, teeth are going to move. And if they start to move, then you're back in retreatment. So this ends the actual formal presentation I have. So at this point, I'm going to open it up to any questions that any of you may have. You can type them in and I'll go ahead and answer anything that you might have. I'll give it a couple minutes for people to type in and all right. Well, sorry, little tickle in my throat. Seems like there are no questions from what I can tell. And I think, I apologize. There's one that just came in. If you have an inclusive fee, do you just add the fee onto your aligner fee? Yes. we just, so what we did, so back in the early days of using vPro, okay, the early days, we would have it as a add-on, and patients had an option. And the option was they could get it, and we would promote it in a similar fashion. But 50% of them said no. And we found that the people, that 50% that said yes, the cases were finishing better and on time. That's why we made it mandatory. We just took the price that we paid for it, made sure we covered our tax, our shipping, and we added it to our aligner fee because we saw the difference. It was quite drastic. We had 50% of our adults not taking the vPro because they didn't want to pay extra for it. And the 50% that took it, finishing treatment on time, better experience, less complaints about sore teeth. So it just became a no-brainer. We just like, okay, forget it. Raise our fee, X hundreds of dollars. It's included now. So we just raised the fee enough to more or less cover our costs, and make sure that, we covered our costs because, once you give it to the patient, there's nothing you need to do with it. So it's just a matter of, passing the cost that you're paying for it on to the patient. That's a great question. Thank you, Mindy. Do you prescribe permanent retainers? I do that's a great question. The times I prescribe permanent retainers, diastemas on the upper arch that are being pesky, right? They're persistent, and the Vivera isn't holding it. Lower crowding, like on that last patient, Sophie. Yeah. If I see that they're having trouble in retention, like things aren't stable, they're having a lot of movement, we'll put one on. Perio patients where I've done a lot of movement and there's, mobility, I'll put one on. But it's not something I do routinely. Routinely we prefer removable retainers, Essex, Vivera, Invisalign retainers. Yeah. Great question. With the V Pro, yeah, they still use Chewies. Yeah, we give them Chewies. They still have Chewies. We give them to them, and we tell them when they put their aligners back in, when they're done eating, to use the Chewy, at that moment to seat it. I mean, I know that the V Pro helps to seat it, but they're only using it for 5 minutes. And patients, when they take them out to eat and put them back in, if they don't have the V Pro with them, which most of them don't, the Chewy can kind of make sure it's seated all the way. So yeah, they still use Chewies. Any adult case you would consider not to use V Pro, like short roots or compromised perio conditions? Like if we've had patients, that's a good question. Yeah, patients who I get nervous when I'm dealing with a patient with root resorption, right? They have maybe previous ortho, or they just have short roots to begin with, right? They just come in with like really short roots. I won't use a V Pro. Or if I'm really dealing with a patient that had a lot of bone loss, like maybe more than 50%, I'm very gun shy about giving them a V Pro because the teeth do move quickly, right? In those cases, right? With the aligners, right? So they get kind of loose and it can be a little, scary at times, especially a lot of times, even on those perio patients, like they're stable, but they've had bone loss, right? I sometimes actually kind of slow down how quickly they're even changing those aligners because we've had some where, things just move so fast. So those might be the two situations where I'm not readily handing those out to those patients because I get a little nervous about doing something that's going to cause a patient to lose a tooth, because of whatever ortho treatment I've done. And last question is, how about patients with implants? How about patients having implants? Yeah, and it's funny, great question. So most of the time, my experience with implants has been the patient is done with treatment, right? They go and get the implant, and they come back, right? They get their final retainer. We have them use the appliance in retention once a week. And I haven't had any, complaints. I mean, in talking, and the periodontists or the oral surgeons that I've used, we've let them know that's what they're doing. It's just a problem. And they haven't said no. So, and patients undergoing treatment that have implants currently, that they come in and they already have an implant, I haven't seen a problem at all. I mean, you know, those implants are already integrated, so it's fine. So hasn't been an issue. That's a good question, though. Thank you for that question. How would I compare VPro to Excellident? Great question. So with Excellident, and we did use Excellident way long time ago. It's 20 minutes, and it's a kind of a light frequency, right? VPro is a much higher frequency, and it's 5 minutes. So just from the patient perspective, 5 minutes is 5 minutes, right? It's a lot quicker, right? And it's a lot less to, it's a lot smaller ask, okay? It's only 5 minutes of their time, right? Versus 20. And there's been so much research to show the high frequency vibration just is so much more effective than the light frequency vibration. So for us, it just makes sense. And, you know, yeah, we used Excellident, you know, maybe for about a year, but that was probably, honestly, gosh, it's got to be at least 8 years ago by now. And I remember patients complaining about it having to be 20 minutes. And, you know, people are always in a hurry today, right? Everything's got to be fast, fast, fast. So 5 minutes, they can kind of do it, check their email, you know, check their Facebook page, check their, you know, start cooking, whatever, and it works. But that's a great question. You came through with some good questions, doctors. I appreciate it. And thank you for your time. And I think that pretty much ends this evening's webinar.